Welcome, ladies and gentlemen. I'm Dr. Silva, and I want to talk a little bit about drug-induced anhedonia, SSRI-induced anhedonia. And that's a fancy term for a side effect that we get when we increase serotonin, typically when we block the reuptake of serotonin. And you have all this extra serotonin around. And that's very useful if you're experiencing agitation, anxiety, irritability, tearfulness. It's good for all of those symptoms, calms everything down. The problem is that it calms everything down. And so one of the main side effects that people get a lot, that they complain about a lot, is sexual dysfunction. They start to lose passion about everything, including in the bedroom. And also, it can generalize to just not getting excited about stuff, crying happy tears, looking forward to things, feeling like going and doing things, going to the gym, etc. And so a lot of times people will complain that they feel, quote unquote, like a zombie, or that they feel flat, that flatline, they don't feel anything, they're numb. And while this is certainly possible, it is a dose-dependent phenomenon, and so if it's occurring, it means that the dose is too high, and we need to reduce the dosage, and you modulate the dose, and that fixes the problem. It can be a little trickier when it comes to sexual dysfunction, because a lot of times what we're talking about there is not just a decreased desire, but also difficulty climaxing and orgasmia, and sometimes that can be a little tricky, but it is dose dependent, it is something that we can address, and really, if you are hyper irritable or having crying jags or having panic attacks and you need that extra serotonin, there is a middle ground. There is a sweet spot. We should be able to alleviate the worst of your symptoms and not turn you into a zombie that just has this flat affect that doesn't feel anything. And that's typically the case. It's very easy. It's really hard to miss that very wide middle ground. But what I see time and time again in the vast majority of cases is that because people have heard about this, they've read about it online, and they're concerned about it, at the first signs of a diminished libido, for example, or at the first signs that they're not crying at the drop of a hat, or I had a patient tell me just today that she had her menstrual cycle, and shouldn't she be a little irritable during the menstrual cycle? Who wants irritability? It's not logical. Nobody wants irritability. That's not a bad thing. But people tend to exaggerate this particular side effect. It's almost always exaggerated. There are some people that don't want to take the medication for whatever reason, and so they'll consciously exaggerate it. But most people will report it sincerely, but they're over-reporting it. They're being sincere, but they're nowhere near flat. But it's because they've looked it up, they've read about it, and so they're overstating their case. And a lot of times they just need to be debriefed, they need to be talked through it, and they do fine. The irony, and where you really see it the most, is those patients who have anxiety spectrum disorders, generalized anxiety disorder, panic disorder, certain forms of, whether it's OCD or social anxiety or whatever the syndrome is. Those patients are so nervous about treatment, period, about taking medication to begin with, and definitely titrating the dosage, increasing the dosage. They're so worried about it that they have anticipatory anxiety about it, and they'll convince themselves that they're flat when they're nowhere near flat. The fact that they are so worried about it shows that they are in fact anxious, and they are nowhere near feeling blah or lackadaisical or unconcerned about things. This one particular symptom that has been so widely reported, you're worried about having it, you're not having it, and not at all in those cases, and the patients will report it. So they actually sincerely report a side effect that they're not even having. But most people will overstate it, and they'll complain of being flat, but then when I meet with them on mental status examination, they're not flat at all. their affect is full, they are actually absolutely still experiencing their emotions, and including some negative emotions, and including more than what we would like, the whole reason that we're treating them to begin with in the first place. So it's just one of those side effects that I think it's probably, I can't think of another side effect off the top of my head that is more over-reported, over-endorsed, exaggerated, consciously or unconsciously, than this particular symptom. And so it sabotages a lot of trials. A lot of people will abort their trials because they're so concerned about this, however conscious they are or not, that they are in fact over-endorsing this particular side effect. So a lot of times when patients don't have an agenda, all they really need is another visit to really kind of deconstruct it, go through it very carefully, look at it, and decide, are they really having this symptom? And if they are, really what's the severity of it? And is it not something that we can't work through? A lot of times patients will complain about when we titrate the dosage for the first time, so we increase the dosage. So sometimes compromising and agreeing to resume the lower dosage as opposed to giving up the medication trial entirely is the best course of action, if only for the psychological benefit of establishing that the patient is still the ultimate person who's going to decide. They're the ones giving informed consent. They are the ones in control, especially for those patients who are anxious, that you're not going to take away control, that they are the ones that are going to decide. And if they feel comfortable resuming the lower dosage, which is grossly subtherapeutic in those patients because they have anxiety, they need the higher doses. But we agree that we're just going to hold at this lower dosage for a while, and then later we can re-challenge with the higher dosage. That's what I did today with one patient who, as soon as I started to point out some of these things, was very quick to acknowledge that yes, it is perhaps more of a concern, and yes, okay, here's evidence that they are in fact having emotions and that they are in fact worried about it, and nobody wants irritability. So a lot of times patients just need a debriefing session. But then there are other patients who have other reasons for not wanting to take SSRIs, and it can still be very helpful to have a conversation with those patients to say, what are the real issues here? What are you really concerned about? Oh, in those patients, it's not that they are completely anhedonic, but that they are slightly anhedonic, and that is really putting a cramp in their lifestyle in terms of their sexual functioning. Because all it takes is a little bit there to cause problems with libido, with orgasm, with erectile dysfunction. All you need is a little bit there. So it's not that they're zombies everywhere else. It's not that they're completely flat, they don't care, they don't react, they don't feel like doing anything. No, that's not the case. That would be very hard to really give you so much serotonin that you're literally flat, especially for patients who are also taking dopaminergic agents. I've had patients complain of this side effect that are taking Adderall. They're taking an amphetamine, a stimulant medication, which balances that out. It increases dopamine. It makes people reactionary. It increases the libido. I mean, there's definitely no way that 10 milligrams of Prozac and a good dose of Adderall for ADD or binge eating disorder or whatever we're taking the stimulant for, you're not going to be a zombie on that combination. But people will complain about it because either they sincerely or insincerely have an issue with taking the Prozac. So when it's due to anxiety, patients maybe need a little hand-holding, a little debriefing, and they can get through it. When they have another reason, and the reason usually is sexual dysfunction, then we can look at that openly and honestly and decide, okay, is this a reason to discontinue the medication? Or is there anything we can do about it? Maybe there's something we can do about the anorgasmia that will also help the anxiety or the insomnia or whatever it is that may be co-occurring. So we really want to be honest about what it is that's making us not want to take the medication, and be honest with yourself, and then be honest with your provider. Don't be shy about saying, okay, here's what it is. Just be honest so that the practitioner can help you weigh the risks and benefits, the pros and cons of what can we do about it. Don't go back to your practitioner and tell them you're a zombie. And I can't even think of a case where I actually saw somebody who was truly, where I had given such a massive dose of an SSRI and they were absolutely reduced to flatline, no emotions, don't care about anything. They care about the dose being too high over here, or about taking the medication, so they care about some things. So anyway, I just want to put that out there for practitioners to really scrutinize, help patients really decide if this is what they really want to do, if what's indicated is a medication that increases serotonin. The serotonergic agents have really gotten a bad rap because of this one particular side effect that I almost never see. Really, I've never seen it, because I've never dosed a medication with such a hideously high dosage that we would be at risk of that. It almost always happens when we initiate treatment or when we begin to titrate the dosage, when we're so far away from the maximum dose that you wouldn't expect to see it anyway. And sometimes I do end up stopping the medication because the patient really just doesn't want to take, and they end up giving me a bunch of other reasons why they don't want to take it. When we look at this one particular reason, I always get like a laundry list of other reasons why they don't want to take it. From weight gain to sexual dysfunction to whatever it is. And so it's rarely a reason to stop the medication, even when we do stop it. Anyway, I hope that helps a little bit, and thanks for watching. Comments are always welcome.